Auzubillahi minash-shaytanir-rajim. Bismillahir-rahmanir-rahim. I'm Professor Muhammad Badar Bashir, and this will be our last lecture, inshallah, in the series of complications of diabetes mellitus. We will discuss today the microvascular diseases, especially the diabetic retinopathy and nephropathy, very briefly. Uh, Diabetic retinopathy, the lesions and natural history are like the first ever change which we do notice in patients of diabetes mellitus in their retinas, that is called as background retinopathy. In background retinopathy, there is capillary dilatation initially, that is later with leakage. As I have mentioned in the previous lecture that the functional changes in microvascular disease is increased permeability, and that increased permeability leads to leakage of these vessels and capillary dilatation. Capillary occlusion microaneurysms are next to come, and then blood hemorrhages and lipid-rich hard exudates. They all can be present in patients with a background retinopathy, that is also called as non-proliferative diabetic retinopathy. Diabetic retinopathy lesions and natural history continues as pre-proliferative retinopathy, that is also part of non-proliferative diabetic retinopathy, but a little more than that of background diabetic retinopathy, and that can also be called another name, that is stage 2 or moderate moderate non-proliferative diabetic retinopathy, as we will learn when we will be discussing about the management. In pre-proliferative stage of the retinopathy, cotton wool spots are seen. They are due to the retinal ischemia. Then certain venous abnormalities are also seen, that appears as loops, bleeding, and reduplication of the vessels. Arterial abnormalities or like variation of caliber, narrowing of segments, and occlusion of the vessels may also be appreciated during this stage. And intraretinal microvascular abnormalities, clusters of dilated abnormal capillaries lying within the retina. They are the stages of pre-proliferative retinopathy. As you can see here, that is a picture of retina of a person with background retinopathy, and in here you can also see other pictures, and soft exudates are appreciated, and here you can also appreciate hard exudates. They are the actually they're the retinal ischemia or retinal infarctive changes. Then comes a proliferative retinopathy. New vessel arise in the periphery and or on the optic disc, eventually with a fibrous tissue covering. The visual complications are caused by vitreous retraction, which leads to hemorrhage and to traction and detachment of the retina. That is the end stage, and that leads to blindness. Maculopathy is also a feature which is a cause of blindness in these patients. It is heralded by rings of hard exudates approaching the fovea. Maculopathy occurs mostly in type 2 diabetics and can cause severe vision loss. Here are certain changes of maculopathy and proliferative retinopathy. You can see the new vessel formation here and hemorrhages in the retina and involvement of macula. Involvement of the macula is visible in this picture, even with the mild changes of retinopathy, which are covering the macular area, may lead to severe visual impairments. So the site of diabetic retinopathy is very important, and if macula is involved, the VN may be involved very earlier on in the time of retinopathy, but it may be delayed till long time if macula is spared throughout the course of the disease. So site of the involvement of the retina is very important. There are certain complications of retinopathy like thrombotic glaucoma. It is due to new vessels and fibrous tissue proliferating in the angle of the anterior chamber that prevents the drainage of the aqueous. It is associated with rubiosis iridis, that is new vascularization of the iris, and causes severe pain and irreversible blindness. Now we will talk about how to follow up these patients of retinopathy, and we there is another type of classification here, that is non-proliferative diabetic retinopathy. When there is no diabetic retinopathy, the patient should be reviewed in 12 months. In cases of very mild disease like microaneurysms only, there are only microaneurysms and no dot and blot hemorrhages, no soft and hard exudates, the patient may be reviewed in 12 months again. Mostly, the patient should be recalled after 12 months for recheckup. But once the disease is mild, any or all of the following, if they are present, the disease is called as mild disease. Microaneurysms, retinal hemorrhages, exudates, cotton wool spots up to the level of moderate non-proliferative diabetic retinopathy. And there is no intraretinal microvascular abnormalities or significant bleeding is present, that comes under the stage of mild disease. Then the patient should be reviewed within 6 to 12 months depending upon the severity of the signs, stability of the disease and systemic factors. If the diabetes is controlled and hypertension is controlled, the patient may be recalled in 12 months. But if they are both uncontrolled and there is also severe dyslipidemia, the patient may be recalled within 6 months. Definitely, the personal circumstances of the patients, they also matter. If the patient is unable to afford the follow-up visits, in those cases, the patients, if and other systemic factors are not unfavorable, the visit may be delayed, but not more than 12 months. The moderate disease includes the severe retinal hemorrhages, about 20 medium to large per quadrant in 1 to 3 quadrants, or mild intraretinal microvascular abnormalities. Significant venous bleeding can be present in no more than one quadrant. Cotton wool spots, they are commonly present. In such cases, the patient should be reviewed within 6 months, because development of proliferative retinopathy, which needs urgent treatment, is very necessary in these cases. Severe background retinopathy or severe non-proliferative or pre-proliferative diabetic retinopathy includes when the severe hemorrhages or in all the four quadrants, significant venous bleeding in two or more quadrants, and moderate intraretinal changes are seen in one or more quadrant. The patient should be reviewed in 4 months, and proliferative diabetic retinopathy is up to 50%, and high risk proliferative diabetic retinopathy in up to 15% within a year they are expected. So these patients needs to be followed up relatively earlier. Very severe means two or more of the criteria which was previously mentioned, they are present. Then the patient is called as the very severe disease, and review should be within 2 to 3 months, because proliferative diabetic retinopathy may develop in up to 45% of patients within a year. When the patient is having proliferative diabetic retinopathy, mild to moderate disease, in mild to moderate disease, new vessels on the disc, that is NVD, or new vessels elsewhere, NVE, but extent insufficient to meet the high risk criteria. The treatment considered according to the severity of the signs, stability, systemic factors, and patient's personal circumstances, such as the reliability of attendance for review. If not treated, review should be within 2 months. In high-risk group, new vessels on the disc, any new vessels on the disc with vitreous or pre-retinal hemorrhages, new vessels elsewhere greater than disc area with vitreous or pre-retinal hemorrhage, or hemorrhage with presumed obscured new vessels on the disc or elsewhere. In these cases, treatment is advised and should be performed immediately when possible, and certainly someday if symptomatic presentation with in certainly same day if symptomatic presentation with a good retinal view is there. Usually, the treatment included the YAG laser treatment, which obstructs and obscures the new vessels in the retina, and other is nowadays intraretinal injections. That is properly dealt with the ophthalmology people, but at least we should know at least how to and when to refer these patients to an ophthalmologist for the treatment. Then comes the diabetic nephropathy. Diabetic nephropathy in albuminuria in diabetic nephropathy is due to glomerular capillary damage and reflects generalized damage to the microcirculation and large vessels too. Nephropathic patients have an increased incidence of retinopathy and a tenfold increase in cardiovascular mortality, which is the major cause of death in nephropathic type 2 diabetic patients. The patients with nephropathy in type 2 diabetes, they tend to die earlier due to cardiovascular problems rather than nephropathy itself. Diabetic nephropathy is defined by persistent albuminuria that is more than 300 milligram per day, declining glomerular filtration rate, and rising blood pressure. Before 300 milligram per day, that is called incipient nephropathy, that is characterized by microalbuminuria, that means 30 to 300 milligram per day of albumin in. We can stage the diabetic nephropathy as that stage 1, also called renal hyperfiltration stage, in which only GFR is increased and renal hypertrophy can be noticed, but there is no albuminuria or microalbuminuria is present. The second stage, that is called the silent stage, renal hyperfiltration, normal urine albumin excretion rate, early histological changes, non-specific increase in basement membrane, as I have mentioned in the last lecture, that structural hallmark of the microvascular disease is the basement membrane thickening and definitely increased in mesangial matrix. The third stage is called as stage of microalbuminuria, in which urine albumin excretion rate is 3 to 30 to 300 milligram in 24 hours. That is also called incipient nephropathy. GFR may elevate or reduced into normal range. Histological changes are the mesangial expansion, glomerular basement membrane thickening, and arteriolar hyalinosis. The fourth stage is established or over nephropathy, that is stage of proteinuria or nephrotic syndrome, in which the protein excretion is more than 300 milligram per 24 hours. In fourth stage, GFR may decline and hypertension is the result of that. And stage 5 is the end stage renal disease. In type 1 diabetic patients, nephropathy develops in about 35% of the cases, especially in males and those whose diabetes presents before the age of 15 years. The incidence of nephropathy peaks after 15 to 16 years of diabetes and declines thereafter. In type 2 diabetics, prevalence of nephropathy is about 10%. Uh, when we talk about the treatment or the prevention of the diabetic nephropathy, there are certain factors which are very important. Amongst those, the excellent diabetic control and aggressive antihypertensive treatment and use of ACE inhibitors is very important. And the preferred agents to be used in patients of diabetes are ACE inhibitors, antihypertensive agents, because they are associated with decrease in chances of nephropathy. And once the nephropathy is developed at the stage of microalbuminuria, if the diabetes is properly controlled and hypertension is also controlled properly with ACE inhibitors, the chance that the changes of microalbuminuria are reversible. But the stage of macroalbuminuria is less, there are less chances that it is reversible, but it can be halted and further damage can be prevented for a lot more days, lot more years to come, if proper glycemic control is there and excellent antihypertensive treatment is given. If the patient is intolerant to ACE inhibitors, in those cases, ARBs are shown to be equally effective in certain clinical trials, and they may be replaced with ACE inhibitors with the same benefit. There are certain trials which show that even introduction of ACE inhibitors, even to the patients, even to the diabetics who are normotensive, also gives benefits in patients with microalbuminuria, and microalbuminuria stage is reversed. So remember that for the treatment of diabetic nephropathy, there are three things which needs to be done. That is, number one, to control diabetes. If the patient is hypertensive, properly control hypertension with ACE inhibitors preferably, and the patient, if the patient is intolerable to ACE inhibitors, ARBs can be used instead. So here we finishes our lectures about diabetes and their complications. You are all welcome to contact me anytime if you don't understand anything about, or you may ask further about these diseases, because what we have discussed, that is very preliminary and very initial about the microvascular diseases. So I hope you will study at home as well, and contact me when you need to ask certain things about the diabetes and its management. Thank you very much, and Allah Hafiz.